So hi everyone, thanks for tuning in. My name is Dr. Moon of New Moon Regenerative Medicine, and I'm here outside on this beautiful day, just able to catch some rays in North Florida. So the weather is nicer here than it has been, so happy to be able to join you guys outside. But today I wanted to talk to you about alternatives to opioids. Just a little bit about me. My background is I am a pain management physician, fellowship trained, and have dealt a lot with narcotic medications, injection therapy, things like that, to help with people in chronic pain, and acute and chronic pain. And over the years, the pendulum has swung differently with how we treat chronic pain and acute pain, actually. And years ago, the focus was on opioids are not addictive for someone that's in pain, and so this pendulum swung particularly in one direction, and pain medicines were kind of given out willy-nilly to help those in pain, and then a problem started to occur with opioid addiction, opioid abuse, overdose deaths, and so forth, and so now the pendulum has swung the other way, where limitations on these medications have become so strict that we're having to really find alternatives, as well as really be kind of conservative and smart in our choices when we discuss pain and pain treatments with patients. And so when it comes to that, on our Medical Monday tip is that we should in a way go back to basics. And so opioids at one point were thought to be a better and more effective treatment for acute and chronic pain. And certain studies and newer studies have found that there may not be any better effect, especially in acute pain. And so there actually was a study that was done in an emergency room, which was a randomized controlled trial, found where they actually had patients where they put them in two different groups, one with a combination of Tylenol and ibuprofen, and the other one the combination of Tylenol and opioids. And so they had about 416 men and women that had come into the emergency room with moderate to severe injuries, kind of like musculoskeletal injuries, sprains, fractures, things like that. And they assigned them to those groups. And in this opioid group, they had oxycodone, hydrocodone, and codeine along with Tylenol. And so they did a follow-up 2 hours later on these patients, and the average score prior to administration of these medications, the average score was about 8.7 pain score. And so 2 hours later, they tested and asked them their pain score, and across the board, there was not any major differences in decreased pain relief, differences in those in the two different groups. So they had all about an average of between 3.5 and 4.9 reduction of pain, whether they were in the Tylenol group and the Tylenol and ibuprofen group, or the Tylenol group with opioids. And so there was no significant difference in those with acute pain. And so at one point, as physicians, we really jumped at having the thought of, if someone's coming in with acute pain, with fractures, with sprains, that we immediately jump to prescribing opioids or stronger medications, when in fact patients did well with the more conservative treatments. And so that's kind of one of the alternatives is anti-inflammatories and Tylenol and acetaminophen to help with acute pain. And that's simplistically speaking. Obviously there are need for opioids, but first line for someone coming in, that's a very basic thing to start somebody. Now, NSAIDs long term obviously can have some issues with GI effect and so on and so forth, but in an acute setting, if no other contraindications and for short periods of time, it can be quite effective for them. Similarly with Tylenol. Over long periods of time, we already know effects of liver, or if in higher doses, effects on the liver, but short term, as well as if there's no contraindications, and Tylenol is an appropriate first-line pain reliever for them. If there are other types of pain, like nerve pain, which is in general also very difficult to treat with traditional narcotic medications, there are antidepressants, anti-epileptic medications that can help for that. that we sometimes don't turn to and explain to patients that, this is a different type of pain. Opioid medications are not in a way indicated for those and are not very helpful with treating those. And so it's education for patients prior to them ever even thinking in their head that narcotics is the answer, is to try these other medications. So antidepressants like amitriptyline, Elavil, Cymbalta, or duloxetine. And in terms of anti-epileptic medications, gabapentin, also called Neurontin, or pregabalin, like Lyrica. So that plays a part with some of the alternatives that we can have for opioids. Other things that can help that are not opioids are steroids. I'll talk in another Medical Monday about my opinion on steroids for certain things, but in an acute setting or to reduce pain and inflammation, it can be appropriate for it. In long-term settings, there are some issues that can come about with some side effects with that, and I'll discuss that at a later time. But in an acute setting, to reduce inflammation and to treat pain, corticosteroids, whether it's oral or injections, can be very helpful so that you can avoid opioid medications. Non-drug treatments, plenty of things to do for that. Once again, education for a patient. So, exercise, physical therapy, really education on a patient with timing of how long an injury should hurt for, and that they injured themselves, that they are going to have some pain. So, as well as yoga, acupuncture, cognitive behavioral therapy. Even for those that suffer from significant issues like burn pain, they've done studies on virtual reality where they've done imaging on the brain to see that different sensory areas light up when they have a distraction like virtual reality. And then also hypnosis. So there are, and I'm only naming a few, there's other things out there that I'm not even touching on. As a pain physician, we do lots of injections, trigger point injections to help for acute pain. And in my clinic specifically, regenerative medicine, which focuses on trying to heal the body from within. So that's another treatment to help for chronic pain, where it can address some of the issues that may not be addressed in therapy or may not be addressed from exercise, and can help strengthen and stabilize some of the areas like ligaments and tendons that have been injured along the way, or just not as strong as they were, or can treat arthritis and stability. And that goes along the same lines as PRP and stem cell therapy, which is along the spectrum of regenerative medicine to help heal the body from within. So lots and lots of different alternatives that are there, but mainly the points are to start back with basics. Don't assume that the patient's not going to respond to traditional anti-inflammatories, the Tylenol, because the studies in that ER setting did show that there were no major differences in patients treated with opioids and the conservative measures. So that's my tip for Medical Monday. I hope that helped. My goal is to try to bring some related factors to what I do in my clinic, as well as the pain management field, as well as I do cosmetic. If you found this Medical Monday tip helpful, please share it. Please like my page. I'm also on Instagram at Dr. New Moon, as well as on Twitter at Dr. New Moon. And comment if you have questions or if you have any other topics that you'd like to hear about. I hope this was helpful, and look forward to next Monday, which most likely I'm going to talk about chronic steroids in the knee and osteoarthritis, and some of the treatments that can be from that and new studies that have come up for that. All right. Thanks for tuning in, and hopefully if you didn't catch it live, that you can be able to catch the replay on it on Facebook. Take care. Thanks. Bye.